Hi everyone, this is Nafis, and in this video we're going to talk a little bit about the management of diabetic ketoacidosis. So let's get right into it. Let's start things off with a brief refresher on the pathophysiology behind diabetic ketoacidosis, or DKA. In patients with type 1 diabetes, where the pancreas is shot and does a lousy job at pumping out insulin, during times of stress when your body needs more energy, this ends up being a huge problem. Your cells need glucose to keep up with the increased energy demands, and insulin helps get that sugar inside the cells to keep them going. But in type 1 diabetics, the pancreas just can't do its job and produce insulin. Without insulin, the sugar can't be pushed into the cells, and all that glucose ends up just staying outside. That causes glucose to accumulate in the blood, so you get hyperglycemia, but since none of that sugar can actually be used, the cells are starving. Since your cells are starved, the failing pancreas thinks it's a good idea to release the other major hormone it produces, which is glucagon, which breaks down energy stores like glycogen and fat. Your body ends up going into this profound catabolic state, and the glycogen gets broken up into glucose, which still can't be used by your cells, and it ends up just making the hyperglycemia even worse. All that glucose overwhelms the kidneys, which try to pee it all out. Since glucose is osmotically active, it pulls water and other electrolytes with it, which all get peed out. This is known as osmotic diuresis, and it causes profound dehydration and classic diabetes symptoms like excessive thirst and urination. Potassium is one of the main electrolytes that gets lost with all that osmotic diuresis, so there's a total body potassium deficit. However, the thing with potassium is that, like glucose, it needs insulin to push it into cells. So even though overall DKA patients are potassium deficient, the potassium levels in the blood can be high, and that hyperkalemia can cause life-threatening cardiac arrhythmias. When glucagon starts the process of breaking down fat, the fatty acids that are metabolized produce ketone bodies that build up and are crucial in times of starvation because they can easily cross the blood-brain barrier and serve as an alternative fuel source for the brain, which is something that fatty acids aren't able to do. The problem with ketones is that they're acidic, and when they build up in the blood, that makes the blood become acidic as well. The result is metabolic acidosis, and they also cause an elevated anion gap. In case you don't know or you need a refresher, the anion gap essentially refers to the quantity of extra negatively charged things that are swimming around in the blood. Blood is supposed to be electrically neutral, so the amount of negatively charged things should be the same as the number of positively charged things. So if we take the positively charged things, which are sodium and potassium, with potassium being ignored since it's usually a very small number, subtracted by the number of negatively charged things we know, which are bicarbonate and chloride, we get some number. Since that number isn't zero, we know that there's some extra negatively charged things going around, which is reflected by the anion gap. Normally it's around 3 to 10 because you have things like albumin that aren't accounted for in the equation. But when it's higher than 12, you know that there's some mystery anions that are making it wider than it should be. In DKA, those mystery anions are the ketones. So there are basically three components of diabetic ketoacidosis that serve as a guide for what to correct. The diabetic part refers to the insulin deficiency, which is reflected by the high blood glucose with dehydration from all that osmotic diuresis and hyperkalemia that's also due to a lack of insulin. There's also the ketone component, which is reflected by the elevated anion gap, and the acidosis, which is reflected by the low pH. The one thing that's going to fix all of these things is insulin. It'll fix the hyperglycemia and hyperkalemia by shifting glucose and potassium into the cells. It also indirectly helps with dehydration because when there's less glucose swimming around, there's less osmotic diuresis, and less fluid gets flushed out by the kidneys as a result. It'll also get rid of the ketones and therefore close the anion gap and correct the acidosis by allowing the starved cells to get some energy from glucose so that they don't need to make acidic ketones anymore. So when looking at the patient, we kind of talked about how we see the classic diabetes symptoms like excessive thirst and urination, but you'll probably also see other symptoms like nausea, vomiting, and abdominal pain. Overall, the patient might look very dehydrated, with dry mucous membranes and decreased skin turgor. Depending on how much volume they've lost, there may be signs of hypovolemic shock, like tachycardia, hypotension, and weak pulses. Evidence of shock is a really bad sign, and volume resuscitation is crucial. Carbon dioxide creates an acidic environment when dissolved in the blood, so the patient might be hyperventilating to get rid of carbon dioxide and offset the acidosis caused by the ketones. That kind of breathing is called Kussmaul respirations. The ketones might also cause a fruity odor on the patient's breath. For the labs, we're looking for an elevated serum glucose, potassium, ketones, and anion gap, as well as a low pH on the blood gases. As for the causes of DKA, you basically just need to think about anything that creates an imbalance between the insulin available and the insulin needed. This often happens because the episode of DKA is the first presentation of type 1 diabetes, or the patient is a known diabetic and missed a dose of insulin. And since the pancreas is really bad at making its own insulin, that creates a catastrophic insulin deficient state. The other causes involve an increased energy demand in the body, where the amount of insulin in the patient's system just doesn't cut it, and their bad pancreas can't keep up. I should also mention that the stress response with these events is associated with an increase in stress hormones like epinephrine and cortisol that sort of act like glucagon and contribute to energy breakdown, which in turn drives ketone production. So those things include infection, ischemia, like a stroke or a myocardial infarction, inflammation, like pancreatitis, substances that cause stress on the body, like cocaine or alcohol, and surgery or trauma. So now let's get into the fun part, which is the management. There's basically three things that we tweak when treating DKA: the volume status, the potassium, and the insulin. That's it. We adjust these things based on what we see on the blood work every 2 to 4 hours, and the blood glucose every hour. Let's look at the fluids part first. Since these patients are extremely dehydrated, we obviously need to get some fluid in them to restore perfusion to their tissues. How we deliver the fluid depends on the timeline of when we started treating the DKA. We can give a 1 to 2 liter bolus of normal saline or lactated ringers in the first hour or so, and then we can keep them on a maintenance rate of 500 cc's an hour for the next 4 hours. And then we can drop them down to 250 cc's an hour from then on. You might give them more dilute fluids, like half normal saline after another 4 hours if their corrected sodium is high or normal, because that indicates that their serum is concentrated and they need more free water. While you're replacing the fluid, you might want to put in a urinary catheter so that you can monitor their urine output. The next thing that you have to think about is the potassium. I don't care how high the potassium looks on labs, because that number is misleading. All DKA patients have a large total potassium deficit because of the osmotic diuresis that we talked about. The number that we see on the labs just tells us how we should go about replacing the potassium. The magic numbers that dictate this are 3.3 and 5. If the potassium is low, meaning less than 3.3, you absolutely cannot give insulin. That might actually kill the patient. Insulin shifts potassium into the cells, and the absolute last thing that you want is to make the potassium get too low, because hypokalemia can cause dangerous arrhythmias just like hyperkalemia can. So not only do you hold the insulin, but you also have to give potassium at 40 millimoles per liter to the IV fluids until you can boost the potassium level to more than 3.3. When it's between 3.3 and 5, you want to give 20 millimoles with each liter of IV fluids to keep it at a happy medium between 4 and 5. This is especially important when you turn on the insulin drip and you want to prevent that dreaded hypokalemia. If the potassium is high, meaning above 5, then stop right there and don't even think about giving potassium, because then you run the risk of causing hyperkalemia and associated deadly arrhythmias. You're going to want to monitor this with blood work for every 2 to 4 hours and adjust things accordingly. The last thing that we look at is insulin. This is an absolutely crucial step. But again, we have to be very careful about starting insulin, because we need to keep an eye on the potassium and the glucose. We actually don't give the insulin for fixing the hyperglycemia like you might think. The hyperglycemia is actually the least of our concerns. The point of giving it is to reverse your body's catabolic state and get it to stop making ketones. So actually, it's for fixing the acidosis and the anion gap. So you might have figured out that the blood pH and the anion gap are the two treatment targets when starting insulin. If the potassium level permits, and I can't stress enough that the potassium needs to be adequate before you do this, you start off by giving a continuous IV insulin infusion of 0.1 units per kilogram per hour. So if we have a 60 kilogram patient, for example, we give a continuous infusion of 6 units of insulin per hour. The nurses tweak this rate based on how the glucose is falling, and while they do this, we make sure that there's a corresponding decrease in the anion gap. While the insulin goes in, the blood glucose is going to keep dropping. Once we get the blood glucose down to 15, that's when we need some sugar in all that fluid that the patient is getting. we want to add 5% dextrose to the normal saline, since you don't want all that insulin you're giving to make things go the other way and cause a low blood glucose, since hypoglycemia is actually life-threatening with the risk of seizures and coma. Ideally, we can keep it somewhere between 12 and 15 to give us a nice cushion for preventing this. So if we pull the fluids part of the chart back up, we basically just add 5% dextrose to the fluids, which in this case is half normal saline. The resulting solution that the patient receives is called D5 half normal saline. The continuous flow of sugar coming through the IV should stop the blood glucose levels from getting too low. So here's the full flow chart. We continue looking at the glucose every hour and the blood work every 2 to 4 hours, keeping a very close eye on the anion gap and the pH. As the anion gap goes down, we slowly turn down the insulin drip as well. Just briefly on the acidosis. I didn't really focus on this because the insulin that we give actually ends up fixing it for the most part. Obviously, as insulin puts a stop to ketone production and closes the anion gap, fewer acidic ketones going around is going to reverse the acidosis as well. If the acidosis is really severe, on the other hand, with a pH of less than 6.9, we have to give 100 milliequivalents of sodium bicarbonate to make the blood a little bit more basic. Otherwise, we can depend on insulin to take care of the rest. As the intravenous insulin infusion continues to go in and do its job, shifting glucose into the starved cells, there's less energy breakdown and resulting ketone production, and the anion gap slowly but surely closes. Once the gap is closed, and assuming the patient is able to eat, that's when we can shut off the insulin drip and transition the patient back to subcutaneous insulin. Before completely shutting off the insulin drip, the patient needs to be on subcutaneous and IV insulin simultaneously for about 1 to 2 hours. Other requirements for this include blood glucose being less than 15, and the insulin requirements are down to 1 unit an hour or less. Once the patient is transitioned, we can dust off our hands and say that our work is done. Well, for managing the DKA anyway. Possibly the most important step while all the other stuff happens is actually figuring out what the underlying cause of the DKA was and managing that accordingly. But that's a topic for another day. So there you have it. I hope you learned something, and if you did, please like the video, share it with your friends, and subscribe to the channel. Until next time, this is Medical Mayhem.